Good day, ma'am. I'm here to explain the steps on perineal suturing. So, when to do perineal suturing? So, if there is perineal laceration. So, perineal laceration is an injury or tear in the vaginal canal or in an outlet that occurs during delivery of the baby. So, since in the checklist is first degree laceration, so women should be advised that in the case of first degree trauma, the wound should be sutured in order to improve healing, unless the skin edges are well opposed. If the tear is left unsutured, the midwife or doctor must discuss the implications with the woman and obtain her informed consent. So details regarding this discussion and consent must be fully documented in the woman's case notes. So labial lacerations are usually very superficial but may be very painful. Some practitioners do not recommend suturing, but if the trauma is bilateral, the laceration can sometimes adhere together over the urethra, and the woman may present with avoiding difficulties. It is important to advise the woman to part the labia daily during bathing to prevent adhesions forming. This is particularly important when caring for women with type 3 FGM. So, steps and perineal suturing. So, first, we must prepare articles in perineal suturing completely, including surgical steel, salt, cotton, and linens. So, second, explain procedure to the mother. If having fully informed the woman why a detailed examination is required to gain her consent. So, in everything that we do as a health professional, so we must ask consent, explain to the mother what we are going to do so that um, makasalig sila ug unsa tang gibuhat ug di sila makuratan. Kay lain pud sid kayo og magsige na ta og ay mo kalit na tag kuan nila kalit na tag tahi without informing them. So the third one is wash hands and dry. So importantly, we must wash our hands thoroughly, and we after washing our hands, so we must dry it to prevent any infection. So the fourth one is wear sterile gloves. So in every procedure that we must do, we need to wear sterile gloves for us to protect ourselves and to prevent any infections. So the fifth one is flush and paint perineum with antiseptic solution. So antiseptic solution or including iodine compounds helps to tighten the vagina and stop the bleeding. So the sixth is expose and explore the vagina and perineum. So after flushing a antiseptic solution, the next thing we do is to explore whether there is continually bleeding, if kanang mas worse pa iyang laceration. So this next is apply firm pressure on bleeding sites. This allows the client's body to deeply relax. So the next, clamp and tie bleeders using small forceps to recognize the perineal tear above the apex site. So next is infiltrate site for repair with lidocaine using local anesthesia technique. So this is to ensure that the wound is adequately anesthetized prior to commencing repair, and this will also help to reduce pain and discomfort caused by skin irritation. So next is start suturing 1 centimeter above the apex of that tear and continue downwards. So after putting a local anesthesia, so start suturing 1 centimeter babaw sa nasandan, no? So and continue downwards. So the next is pull thread not too tight and not too loose. So after nimo after ka nag-suture og 1 centimeter above, so pull the thread, di pud kayo hugot, di pud kayo luag. So dapat sakto ra siya kay di pud siya kayo sakit, di pud sakto ra, dapat sakto ra jud. So the next is make an interrupted suture in the skin edges from the foreshape to align vagina opening properly. So maghimo kag interrupted suture sa katong skin edges gikan sa foreshape to align vagina para ma-open siya tarong. So the next is stitch muscle to muscle and mucosa to mucosa. So after ka naghimo og interrupted suture sa skin edges, so tahion nimo ang muscle to muscle and mucosa to mucosa. The next is push the edges together to make sure that they are correctly approximated. So after kaning stitch sa muscle to muscle, imong i-push ang edges dungan para ma-make sure nimo nga way nahabilin na kuan. Para make sure nimo nga kuan sila together to correctly approximated. So the next is be sure that the suture did not go through the anus or rectum. Check it by inserting one finger in the woman's anus. So kani importante ni kay basin ka ng wa ta gabantay nga sa ato ri pagtahi ning lapas na siya sa kuan hingdong na sa anus. So another degree of laceration na pud na. So by ensuring that the suture did not go through the anus, so we will check it by inserting one finger to the woman's anus. So the next is when the laceration has been closed, inspect suture areas for any dead space. So if imong pagtahi is kanang na-close na ka, so mag-inspect ka nga yamukay na kuanan nga mga dead space. Next, do vaginal rectal examination likewise. So after ka nagtahi, as in humana jud kag tahi, so we must do the vaginal rectal examination to examine and identify abnormalities in the pelvic area, most specifically those of the uterus and ovaries. So it provides them the means to feel deep inside the pelvis to determine where and how large the pelvic organs are. And by doing the vaginal rectal examination, this is to make sure that no stitches can be felt in the rectum. After doing the vaginal rectal examination, so we must clean and disinfect the area. By keeping the area clean and dry as possible, will help the healing of wounds. So the next is put a sterile pad. And lastly, place mother in a comfortable position so that the mother feel a comfort, though she is in pain, but we should place her in a comfortable position. So that would be all on steps on perineal steps on internal examination. Before I explain the steps on internal examination, let us know first when to do and when not to do an internal examination. So when to do an internal examination? Only during labor. If the bowel ruptures, to rule out the cord prolapse. If malpresentation is suspected on abdominal examination. And before transferring a woman to another facility to ensure she is not likely to deliver on the journey. And lastly, in the third stage, if there is a postpartum hemorrhage caused by retained placenta or placental fragments or suspected laceration. So, when not to do an internal examination? If woman has had a vaginal bleeding after 5th month of pregnancy, considering the possibility of placenta previa. And if the mother has high blood pressure, either diastolic blood pressure equal to or more than 100 mmHg. And lastly, if without a good indication for doing so, every IE may bring infection to the woman and her baby. So now, I will explain the steps on internal examination. So first, prepares articles completely. Involves the midwife putting on sterile and often using as antiseptic cream applied to the first and second fingertips so that he can gently examine the woman's cervix. So, next is explain to the woman what you are going to do. So, as I said earlier, that and everything that we must do, we should explain to the patient what we are going to do, and we must ask a consent. So, the third one is put the mother in a dorsal recumbent position. So, dorsal recumbent position is a position which the patient lies on the back with the lower extremities moderately flexed and rotated outward. It is employed in the application of obstetrical forceps, repair of lesions following parturitions, and vaginal examination. Next, take full aseptic precautions. meaning using practices and procedures to prevent contamination from pathogens. It involves applying the strictest rules to minimize the risk of infection. And this will also protect patients from harmful bacteria and other pathogens during medical procedures. So next is rinse the vulva with clean water. Hugasan mo ang vulva sa hinlo nga tubig to avoid getting any infections. Next is wash hands and dry. We should wash our hands properly and thoroughly. And after hand washing, we make it dry. So next is put on sterile gloves. Everything that you do in the hospital, we should observe sterility. So we should wear a sterile gloves. So after putting on sterile gloves, we should now inspect the vulva. If there is amniotic fluid, is it clear or meconium stained? Kung clear ba o meconium stained ang bag of water. So next is there any abnormal discharge or blood or pus? So as you inspect the vulva, nabay ka ng mga abnormalities like blood or pus, nabay mga nana ato. So next is apply sterile water, soluble lubricating jelly into the second or the index and the third or middle finger of the examining hand. So after checking if there is abnormal discharges, apply sterile water soluble lubricating jelly into the second and third finger. Kaya mao to siya imong isud sa vulva. So next is ready your lubricated hand for insertion. So after ka nagbutang og lubricating jelly sa imong duha ka fingertips, iandam nimo for insertion to do the internal examination. So next is separate the labia with the thumb and little finger of the right hand. So katong duha ra imong isud and ibuwag nimo ang duha nga nabilin nga fingertips and the thumb. So you're going to do like this. Then so next is insert the second and third fingers sidewise deep into the vagina. So isud nimo ang duha ka kamot sa gilid sa vagina. So nimo. And next is feel inside the vagina with the index and middle fingers. So as your two fingertips are inside, so feel inside the vagina. Kung nasud na imong duha ka fingertips, i-feel nimo kung pila naka cm ang presenting part. So next is direct your second and third fingers toward. So direct nimo tong duha kanimo ka fingertips. So next is flex your fourth and fifth fingers inward to the palm and of the hand. So i-flex nimo, imo siyang kuan ka aron kay basin og fully dilated na. So mas maguot jud imong kuan, imong kamot. So flex your fourth and fifth fingertips. So next is point the thumb forward. So i-point nimo imong thumb forward. Insert the middle and index fingers carefully into the vaginal up to the cervix, gradually rotating the hand in the process until the palm faces upward and the fingers come in contact with the cervix. So dapat imong kamot is maingani na, kaya dapat ang palm is atubang siya upward. Next is reinforce the instructions on relaxation technique. So while doing those things, you should reinforce the instruction. Ingnon gyapon imong mama nga ma'am, relax sa dapat. Kay wala kay angay nga problemahon kay I'm just doing an internal examination. So next is the thumb rests on the symphysis pubis externally and the fourth and fifth fingers are kept flexed and not in contact with the anus. So next, note the following during internal examination. So the following are you are going to note during internal examination. So first, condition of the cervix, whether the cervix is hard, soft, closed, or open. So as you do the internal examination, you check nimo ang cervix if hard ba siya, soft ba, if open ba, or closed. So cervical dilatation per centimeter is to assess the cervical dilation. Insert the middle and index finger into the open cervix and gently open them to the cervical rim. So inisod nimo sa imong kamot, hinahinayon nimo gently open them to the cervical rim para makaibaw ka og pila na ka cm. So the distance between the outer rim of both fingers is the cervical dilation. So ang distance sa imong duha ka fingertips mo na siya ang cervical dilatation. So if ana or fully na jud, so the approximate diameter of cervical opening in centimeters is estimated during using these fingers. So mas approximate if you do an internal examination if you use this two fingertips, the middle and the index. So the second thing that you must note during internal examination is presentation of fetus. So whether it is breech, cephalic, shoulder, and others. So bridge presentation is when the fetus presents buttocks or feet first rather than head first, which is the cephalic presentation. So cephalic, it is ideal for labor. The baby head down, facing the mother's back, with a chin tucked to its chest and back of the head ready to enter the pelvis. Shoulder presentation refers to a malnutrition at childbirth where the baby is in a transverse lie, thus the leading part is an arm or shoulder or the trunk. However, shoulder and bridge presentation um, shows a malposition. Malpresentation rather. So the third thing that you do note is the position, whether it is LOA or left occiput anterior. Left occiput anterior, it is the most common in labor. The baby's head is slightly off center in the pelvis with the back of the head toward the mother's left thigh. So if the position is LOP or left occiput posterior, this is if the baby is facing forward and slightly to the left, looking toward the mother's right thigh. The third one is the ROA or the right occiput anterior. This is when the baby's head is slightly off center in the pelvis with the back of the head toward the mother's left thigh. So the ROP or the right occiput posterior, this is when the baby is facing forward and slightly to the right, looking toward the mother's left thigh. So the fourth thing you do note on doing the internal examination is the station. Station means location of the fetus inside the mother's womb. So -3 posterior to the posterior of cervix. So -2 stands for mid position of the cervix, and -1 stands for the interior of the cervix. However, -5 to 0 means the presenting or most palpable part of the baby is above the woman's scalp spines. Sometimes a doctor can feel the presenting part. This station is known as the floating. And if the sign is +1 or the +1, this indicates 1 to 2 centimeter. And if +2, this indicates 3 to 4 centimeters. And if +3, this indicates 5+ centimeter, 5 and above. So otherwise, positive numbers means used when a baby is descended beyond the scalp spines. So during birth, a baby is at the +4 to positive station. So the fifth thing that we must take note during internal examination is the condition of the bag of water or membranes. So if it is intact or ruptures. So in intact, if the bag of water is intact, this means that the presenting part is high. So it is usually quite easy to feel intact membrane. So if the bag of water is ruptured, whether it is whether it is clear, absent, meconium, and bloody, those are the characteristic of amniotic fluid. So the sixth thing that we must take note during internal examination is pelvic architecture. So first, scalp spine. Scalp spine is can be palpated at about a finger length into the vagina. They are felt as body prominence. It can be uncomfortable for the woman when we press on it. So next is prominent and not prominent. So second sub part of pelvic architecture is diagonal conjugate. So if 11.5 centimeter, this not 11.5 centimeter, it is called adequate intertuberous diameter. So and if greater than 11.5 centimeter, it is called as adequate diagonal conjugate. And the last thing that we must take note during internal examination is assessing vagina and perineum. So by assessing vagina and perineum, whether the vagina is firm and distensible. So firm is having a solid, almost unyielding surface or structure. So while distensible, it is capable of being dilated or expanded. So that would be all on the steps on internal examination. Thank you for listening.